Friends, welcome to my workplace at Ranaghat, West Bengal, India. This patient presented with severe pain in the eye, redness, vomiting, severe headache, etc. 2 days back. Intraocular pressure was 68 mm of mercury. The antechamber was deep and it was a hypermature Morganian cataract. So it is a case of Phacolytic glaucoma. After anti-glaucoma medications, the intraocular pressure has come down to 30 mm of mercury, and I have taken up this case for surgery. By this time, the main incision and 2 side boards have been made. And now I am going to stain the anterior capsule of this cataract underneath this air bubble. If you stain underneath an air bubble, the staining is immediate. It takes very less time. The staining is very good. Now the dye is washed out with the help of a 23G Simcoe. And now, after washing the dye out, 2% hydroxypropyl methyl cellulose is injected into the anterior chamber. The antechamber is filled up with this visco. And now capsulorhexis is to be done. I take a 26G bent needle, go through the right side port, incise the anterior capsule, and milky fluid comes out. Yes, if milky fluid comes out, the intralenticular pressure is not raised much. I repeat, if milky fluid comes out, intralenticular pressure is not raised much. And you can do rhexis at on go. And that is what I am doing with the help of a Utrata forceps. At this time, it should be very slow and gentle and steady. Don't give a jerky pull because the geniole may be weak in such cases, though the geniole appears to be okay in this case. And now, hydrodissection is not required. The tip of the Phaco handpiece is being introduced with its bevel down, with its bevel towards the nuclear mass. Such cases, you must engage with bevel down, because if it is bevel up, the nuclear mass will go this way and that way. You cannot engage the Phaco tip into the nuclear mass if the bevel is up. So the bevel should be down, and you can hold the nuclear mass, make a trench, and try to chop this hard brown nucleus without any support of epinucleus. Yes, there is no epinuclear cushion. So we have to be very careful in such cases. By this time, the nucleus has been tilted a bit and some cracks have been made. Yes, in such cases, no particular technique works. We have to be gentle, and we have to do such cases somehow. Do it somehow. DISS. So it is dish technique. But we have to be very gentle. We have to utilize our past experiences. Past experiences of maybe decades. I have experience of Phaco from 1998. So it is about 2 decades. With this experience, I can do it somehow. And now I'm trying to crack. Somehow I have to manage it. I hold the nuclear mass. The bevel of the phaco tip is facing the nuclear mass. And now I rotate, apply vacuum, and here it is. I emulsify this portion. Actually, I am tilting this nucleus, and the portion which is just above the anterior capsule, the supracapsular portion, is being emulsified. You can see that a rat is munching a piece of bread, but the nucleus should be tilted because one equator will support the posterior capsule and the other equator, which is above the anterior capsule, which is just above the anterior capsule, is eaten up. Very slowly, very steadily, this is managed. This portion, the nucleus management portion of this surgery, is not edited at all. The other portions are edited a bit. The periods of inactivity has been omitted. And now this last bit of nucleus, leave it. Don't try to emulsify it. I repeat, the last bit of nucleus, don't try to emulsify this. As soon as you emulsify this, the posterior capsule will come forward, and you may make a posterior capsular rent. So inject visco, place the lens in the capsular bag. These patients are usually poor. They cannot afford a hydrophobic intraocular lens. But hydrophilic intraocular lenses are good. Only thing is there can be PCO, that is posterior capsular opacification. You can do YAG laser capsulotomy later on. Now, after placing the lens, go again with the tip of the phaco handpiece and emulsify this last bit of nucleus. Some of my colleagues have shown that the whole nucleus is being emulsified, first implanting the lens. This is not necessary. As soon as you implant the lens occupies some space, and you have to emulsify the hard nucleus in the anterior chamber, most of the hard nucleus, and there can be endothelial cell loss. But if you just emulsify the last small bit of nucleus over the support of the lens, over the platform of the intraocular lens, then endothelial cell loss will be very minimal. We will see that in that case. There are post-op pictures at the end of this video. At this time, the sight boards are being hydrated. The corneal stroma on either side of the sight boards are hydrated, and these stab incisions close. They become watertight. Now, this is a bit of dexamethasone. These patients usually have post-operative inflammatory reactions So I have used a bit of dexamethasone. Though I am washing it out, few molecules of dexamethasone will remain, and this will decrease the inflammatory response. Now this is the final lavage of the anterior chamber. The anterior chamber is formed very nicely. The integrity of the wounds are checked, and this is subconjunctival dexamethasone. We started from here and we have reached here. So this has been a very satisfactory journey. These are the post-op pictures after 2.5 hours. Yes, after 2.5 hours. The surgery was done at 12 o'clock, and these are the pictures at 2:30. See, very minimal corneal edema, and this is the fundus, and the optic nerve appears okay. Thank you very much for your attention. Hope this video will inspire you to take up challenging cases for phacoemulsification. Will give you very necessary tips and tricks of managing such cases. Thank you very much for your attention.